Lewis's Medical Surgical Nursing, 11th edition, Chapter 33, Coronary Artery Disease and Acute Coronary Syndrome. Cardiovascular disease, CVD, is the leading cause of death both globally and in the United States. CAD is the most common type of CVD. CAD was an underlying cause of death in about 1 of every 7 deaths. Patients with CAD may be asymptomatic or develop chronic stable angina, chest pain. CAD may evolve to more serious conditions of unstable angina and myocardial infarction, which are referred to as acute coronary syndrome. Conceptually, CAD has a profound effect on perfusion. The process of perfusion is based on the heart's ability to generate enough cardiac output, CO, to distribute blood to all body tissues. CAD negatively affects cardiac function, resulting in impaired CO and decreased perfusion. This chapter discusses the care of patients with CAD, chronic stable angina, and ACS, and measures to promote optimal perfusion. Coronary artery disease. CAD is a type of blood vessel disorder that we consider in the general category of atherosclerosis. The term atherosclerosis comes from 2 Greek words, athere, meaning fatty mush, and scleros, meaning hard. This combination means that atherosclerosis begins as soft deposits of fat that harden with age. This is why many refer to atherosclerosis as hardening of the arteries. It can occur in any artery in the body. When the atheromas, fatty deposits, form in the coronary arteries, the disease is called CAD. The term arteriosclerotic heart disease, ASHD, cardiovascular heart disease, CVHD, ischemic heart disease, IHD, coronary heart disease, CHD, are other terms used to describe CAD. They are often used interchangeably. Etiology and pathophysiology. Atherosclerosis is the major cause of CAD. It's characterized by lipid deposits within the intima of the artery. Endothelial injury and inflammation play a key role in the development of atherosclerosis. The endothelium, inner lining of the vessel wall, is normally non-reactive to platelets and leukocytes, as well as coagulation, fibrinolytic, and complement factors. Damage to the endothelial lining can result from tobacco use, hyperlipidemia, hypertension, toxins, diabetes, high homocysteine levels, and infection, causing a local inflammatory response. C-reactive protein, CRP, a protein made by the liver, is a nonspecific marker of inflammation. CRP levels rise when there is systemic inflammation, such as rheumatoid arthritis or inflammatory bowel disease. CRP and levels of lipoprotein A, which has pro-inflammatory properties, are increased in many patients with CAD. CRP and lipoprotein A are not a part of a routine risk assessment for CAD. They can be used in patients with an intermediate or high risk suspicion of CAD. Developmental stages. CAD is a progressive disease that develops in stages over many years. When the patient becomes symptomatic, the disease process usually is well advanced. Stages of development in atherosclerosis are 1. Fatty streak, 2. Fibrous plaque, and 3. Complicated lesion. Fatty streak. Fatty streaks, the earliest lesions of atherosclerosis, are lipid-filled smooth muscle cells. As streaks of fat develop within the smooth muscle cells, a yellow tinge appears. Fatty streaks can be seen in the coronary arteries by age 20. They involve an increasing amount of surface area as one ages. Treatment that lowers Low density lipoprotein, LDL cholesterol, may slow this process. Fibrous plaques. The fibrous plaque stage is the beginning of progressive changes in the endothelium of the arterial wall. These changes can appear in the coronary arteries by age 30 and increase with age. Normally, the endothelium repairs itself immediately. This does not occur in the person with CAD. LDLs and growth factors from platelets stimulate smooth muscle proliferation and thickening of the arterial wall. Once endothelial injury has taken place, lipoproteins, carrier proteins within the bloodstream, transport cholesterol and other lipids into the arterial intima. Collagen covers the fatty streak and forms a fibrous plaque with a grayish or whitish appearance. These plaques can form on one side of the artery or in a circular fashion involving the entire lumen. The borders can be smooth or irregular with rough, jagged edges. The result is a narrowing of the vessel lumen and reduced blood flow to the distal tissue. Complicated lesion. The last stage in the development of the atherosclerotic lesion is the most dangerous. As the fibrous plaque grows, continued inflammation can result in plaque instability, ulceration, and rupture. Once the integrity of the artery's inner wall is compromised, plaque rupture, platelets accumulate in large numbers, leading to a thrombus, platelet aggregation and adhesion, as the body's attempt to heal the ruptured area. The thrombus may adhere to the wall of the artery, leading to further narrowing or total occlusion of the artery. Activation of the exposed platelets causes expression of glycoprotein 2B3A receptors that bind fibrinogen. This in turn leads to more platelet aggregation and adhesion, further enlarging the thrombus. At this stage, the plaque is referred to as a complicated lesion. Collateral circulation. Normally, some arterial anastomosis, or connections called collateral circulation, exist within the coronary circulation. Two factors contribute to the growth and extent of collateral circulation. One, inherited predisposition to develop new blood cells, angiogenesis, and two, presence of chronic ischemia, poor blood flow. When plaque blocks the normal flow of blood through a coronary artery and the resulting ischemia is chronic, increased collateral circulation may develop. Blockages in coronary arteries occur slowly over a long time. There is a greater chance of collateral circulation developing, so the heart muscle may still receive an adequate amount of blood and oxygen, except during increased workload of the heart, such as exercise. However, with rapid onset CAD, e.g. familial hypercholesterolemia or coronary spasm, there's not enough time to develop collateral circulation. When this happens, reduced blood flow results in more severe ischemia or infarction. Risk factors for coronary artery disease. Most risk factors have been associated with CAD. We group them as non-modifiable and modifiable. Non-modifiable risk factors are age, gender, ethnicity, family history, and genetics. Modifiable risk factors include high serum lipids, high BP, tobacco use, physical inactivity, obesity, diabetes, metabolic syndrome, physiologic states, psychologic states, and homocysteine levels. Non-modifiable risk factors. Age, gender, ethnicity, and genetics. The incidence of CAD is highest among middle-aged men. However, the risk for CAD increases for men over age 45 and women over age 55. Heart disease is often diagnosed about 10 years later in women than men. One possible reason for this may be the cardioprotective effects of estrogen. But, interestingly, hormone replacement therapy does not protect women after menopause and may be harmful. Because women are older at the time of CAD diagnosis, they are more likely to have comorbidities, e.g. hypertension, diabetes. Women are more likely than men to die after their first MI. CAD is present in Black women at rates higher than their white or Hispanic counterparts. Most women do not consider CAD their greatest health risk. Despite efforts to increase awareness that more women die from heart disease than from breast cancer, heart disease kills almost 10 times more women than breast cancer. It is the leading cause of death in women. When women present to the HCP, their symptoms may be unrecognized as heart-related because symptoms are often atypical. These symptoms include fatigue, shortness of breath, upper back pain, indigestion, weakness, sleep problems, palpitations, and anxiety. These atypical symptoms can relate to many different diseases and syndromes. This lack of recognition of symptoms as a cardiac problem leads to delay in women seeking treatment and HCPs recognizing the symptoms. Genetic link. Genetic predisposition is a key factor in the occurrence of CAD. Family history is a risk factor for CAD and MI. Often patients with angina or MI can name a parent or sibling who died of CAD. The genetic basis of CAD/MI is complex and poorly understood. We estimate that the genetic contribution to CAD is as high as 40 to 60%. This proportion relates mainly to genes that control known risk factors, e.g. lipid metabolism. Major modifiable risk factors. High serum lipids. A high serum lipid level is a major risk factor for CAD. The risk for CAD is associated with a total serum cholesterol level greater than 200 milligrams per deciliter, an LDL greater than 130 milligrams per deciliter, a high-density lipoprotein level less than 40 milligrams per deciliter in men and less than 50 milligrams per deciliter in women, and or a fasting triglyceride level greater than 150 milligrams per deciliter. For the body to be able to use and transport lipids, they must be soluble in blood by combining with proteins. Lipids combine with proteins to form lipoproteins. Lipoproteins are vehicles for fat mobilization and transport. They vary in composition. The major three lipoproteins are HDLs, LDLs, and very low density lipoproteins, VLDLs. HDLs contain more protein by weight and fewer lipids than any other lipoprotein. HDLs carry lipids away from arteries to the liver for metabolism. This process of HDL transport prevents lipid accumulation within the arterial walls. Therefore, high serum HDL levels are desirable and lower the risk for CAD. Premenopausal women usually have higher HDL levels than men. This may be related to the protective effect of natural estrogen. After menopause, women's HDL levels decrease to levels near those of men. In general, HDL levels are higher in women, decrease with age, and are low in those with CAD. Physical activity, eating more healthy fats, losing excess weight, moderate alcohol intake, and quitting smoking help increase HDL levels. LDLs contain more cholesterol than any of the lipoproteins and have an attraction for arterial walls. High LDL levels correlate closely with an increased incidence of atherosclerosis and CAD. This is why low serum LDL levels are desirable. We cannot routinely calculate LDL if the triglycerides are higher than 400 milligrams per deciliter. VLDLs have a higher concentration of triglycerides and can deposit cholesterol directly on the walls of the arteries. Triglycerides are the most common type of fat in the blood. A certain amount of triglycerides is needed for bodily function, but high triglyceride levels may increase the risk for CAD. Certain diseases, e.g. type 2 diabetes, chronic kidney disease, drugs, e.g. corticosteroids, hormone therapy, and genetic disorders have been associated with high triglyceride levels. Lifestyle factors that can contribute to high levels include high alcohol intake, high intake of refined carbohydrates and simple sugars, and physical inactivity. When a high triglyceride level is combined with a high LDL level, a smaller, denser LDL particle is formed, which favors deposition on arterial walls. People with insulin resistance often have this pattern. Guidelines for treating high LDL cholesterol are based on a person's 10-year and lifetime risk for having heart disease or stroke. The following data generate a risk score. 1. Age. 2. Gender. 3. Race. 4. Use of tobacco. 5. Diabetes. 6. Systolic BP. 7. Diastolic BP. 8. Use of BP drugs. 9. Total cholesterol level. And 10. HDL cholesterol level. A 10-year risk calculator is available at blah-blah-blah.com. The 2013 American College of Cardiology, American Heart Association cholesterol guideline does not promote treating LDL to target goals, as had been recommended in earlier guidelines. However, the 2017 American Association of Clinical Endocrinologists guideline endorses treating LDL to specific target goals. The AACE guideline states that those with no cardiac risk factors are considered at low risk for the development of CAD. Their LDL goal is less than 130 milligrams per deciliter. Those with 2 or less risk factors and a 10-year risk of less than 10%, moderate risk, should be treated to an LDL target of less than 100 milligrams per deciliter. Those at high risk, greater than 2 risk factors and 10-year risk of 10-20%, or diabetes or CKD stage 3 or 4, with no other risk factors, should be treated to an LDL level of less than 100 milligrams per deciliter. Those at very high risk for developing CAD, recent hospitalization for ACS, established CAD, carotid disease or peripheral vascular disease, diabetes, CKD stages 3 to 4 with 1 or more risk factors should be treated to an LDL target of less than 70 milligrams per deciliter. Hypertension. Hypertension increases the risk for CAD, stroke, peripheral vascular disease, heart failure, and death. In postmenopausal women, hypertension is associated with a higher incidence of CAD than in men and premenopausal women. According to the most recent published hypertension guidelines, a normal BP is defined as less than 120 millimeters of mercury over less than 80 millimeters of mercury. BP is classified as elevated, 120 to 129 over less than 80. Stage 1 hypertension, BP 130 to 139 over 80 to 89, or stage 2 hypertension, BP greater than 140 over greater than 90. The cause of hypertension in 90% of those affected is unknown, but it is usually controllable with lifestyle changes and medications. Lifestyle changes are a part of therapy for all people with elevated BP and hypertension. Those with stage 1 or 2 hypertension usually need drug therapy, often more than one drug, to reach therapeutic goals. Teach patients the importance of achieving and maintaining target BP goals. The shearing stress of an elevated BP causes endothelial injury that increases the rate of atherosclerosis. Atherosclerosis, in turn, causes narrowed, thickened arterial walls and decreases the distensibility and elasticity of vessels. More force is needed to pump blood through diseased arteries. This increased force is reflected in a higher BP. This added workload results in left ventricular hypertrophy and decreased stroke volume with each contraction. Tobacco use. A third major factor in CAD is tobacco use. The risk for developing CAD is much higher in those who smoke tobacco or use smokeless tobacco than in those who do not. Further, tobacco smoking decreases estrogen levels, placing premenopausal women who smoke at greater risk for CAD. Nicotine in tobacco smoke causes catecholamine, i.e. epinephrine, norepinephrine, release. These neurohormones cause an increased heart rate, HR, peripheral vasoconstriction, and increased BP. These changes increase the heart's workload. Tobacco smoke is related to an increase in LDL level, decrease in HDL level, and release of toxic O2 radicals. All of these add to vessel inflammation and thrombosis. Carbon monoxide, found in tobacco smoke, affects the O2 carrying capacity of hemoglobin by reducing the sites available for O2 transport. Thus, the effect of an increased cardiac workload and the O2 depleting effect of carbon monoxide significantly decrease the O2 available to the heart muscle. We also believe that carbon monoxide is a chemical irritant that injures the endothelium. The benefits of smoking cessation are dramatic and almost immediate. CAD mortality rates drop to those of non-smokers within 12 months. However, nicotine is highly addictive. People usually need intensive intervention to quit. Individual and group counseling, nicotine replacement therapy, and smoking cessation drugs, e.g. bupropion, varenicline, are examples of smoking cessation strategies. Non-smokers exposed to secondhand tobacco smoke increase their risk for CAD by 25 to 30%. People who live in the same house as the person who smokes should encourage that person to quit. This reinforces the person's effort and decreases the risk for ongoing exposure to environmental smoke. Pipe and cigar smokers who often do not inhale have an increased risk for CAD similar to those exposed to secondhand smoke. The few studies on e-cigarettes suggest they increase heart rate and BP through systemic absorption of nicotine. Physical inactivity. Physical inactivity is the fourth major modifiable risk factor for CAD. Physical inactivity implies a lack of adequate physical exercise on a regular basis. The ACC and the AHA recommend 30 to 60 minutes of exercise, such as brisk walking, at least 5 days per week. How physical inactivity predisposes a person to CAD is still unclear. Physically active people have increased HDL levels. Exercise improves thrombolytic activity, thus reducing the risk for clot formation. Exercise may help with the development of collateral circulation in the heart. Exercise training for those who are physically inactive reduces the risk for CAD through more efficient lipid metabolism, increased HDL production, and more efficient O2 extraction by the muscles. This decreases the heart's workload. For people with CAD, regular physical activity may reduce symptoms, improve functional capacity, and improve other risk factors such as insulin resistance and glucose intolerance. Obesity. The death rate from CAD is higher in obese persons. Obesity is defined as a body mass index of greater than 30 and a waist circumference more than 40 inches for men and more than 35 inches for women. We calculate BMI by dividing a person's weight in kilograms by the square of the height in meters. The increased risk for CAD is proportional to the degree of obesity. Obese persons may make increased levels of LDLs and triglycerides, which are strongly related to atherosclerosis. Obesity is often linked with hypertension and insulin resistance. People who tend to store fat in the abdomen, an apple figure, rather than in the hips and buttocks, a pear figure, have a higher incidence of CAD. Contributing modifiable risk factors. Diabetes mellitus. The incidence of CAD is 2 to 4 times greater among people who have diabetes, even those with well-controlled blood glucose levels. A patient with diabetes manifests CAD more often and at an earlier age. There is no age difference between males or females with diabetes in the onset of symptoms of CAD. Undiagnosed diabetes is often discovered when a person has an MI. A person with diabetes has an increased tendency towards endothelial dysfunction. This may account for the development of fatty streaks in the arteries. Patients with diabetes also have changes in lipid metabolism and tend to have high cholesterol and triglyceride levels. Management of diabetes should include lifestyle changes and drug therapy to achieve a A1C level of less than 7%. Metabolic syndrome. Metabolic syndrome refers to a cluster of risk factors for CAD whose underlying pathophysiology may be related to insulin resistance. These risk factors include central obesity, hypertension, abnormal serum lipids, and a high fasting blood glucose. These interrelated risk factors appear to promote the development of CAD. Psychologic states. Certain behaviors and lifestyles may contribute to the development of CAD. One type of behavior, referred to as type A, includes perfectionism and a hardworking, driven personality. The type A personality often suppresses anger and hostility and has a sense of time urgency, is impatient, and creates stress and tension. This person may be more prone to MIs than one with a type B personality, is more easygoing, takes upsets in stride, knows personal limitations, takes time to relax, and is not an overachiever. However, the relationship between behaviors and the risk for CAD MI is controversial and complex. Psychologic risk factors thought to increase the risk for CAD include depression, acute and chronic stress, e.g. poverty, serving as a caregiver, anxiety, hostility and anger, and lack of social support. Stressful states contribute to the development and progression of CAD. Sympathetic nervous system (SNS) stimulation and its effect on the heart are the physiologic mechanisms by which stress predisposes a person to the development of CAD. SNS stimulation causes an increased release of catecholamines, i.e. epinephrine, norepinephrine, which may contribute to endothelial injury, inflammation, and platelet activation. SNS stimulation also increases heart rate and the force of myocardial contraction, which increases myocardial O2 demand. Stress-induced mechanisms can cause elevated lipid and glucose levels and changes in blood coagulation, which contribute to the development of atherosclerosis. Homocysteine. High blood levels of homocysteine are linked to an increased risk for CAD and other CVDs. Homocysteine is made by the breakdown of the essential amino acid methionine, which is found in dietary protein. High homocysteine levels may contribute to atherosclerosis by 1. Damaging the inner lining of blood vessels, 2. Promoting plaque buildup, and 3. Changing the clotting mechanism to make clots more likely to occur. Although folic acid lowers homocysteine levels, research has not shown that reducing homocysteine levels lowers the risk of CAD. Substance use. The use of illegal drugs, such as cocaine and methamphetamine, can produce coronary artery spasm, resulting in myocardial ischemia and chest pain. Most patients with drug-induced chest pain initially cannot be distinguished from those with CAD. They often have sinus tachycardia, high BP, and chest pain. Chest pain occurs because of increased myocardial O2 demand from the increased HR and contractility and coronary vasoconstriction. An MI can occur because of coronary spasm. Serum cardiac biomarkers and ECG help determine if the patient is experiencing ACS. A drug screen may be helpful to identify what precipitated the cardiac event. Interprofessional and nursing care, coronary artery disease, health promotion. Management of CAD risk factors may prevent, modify, or slow disease progression. In the United States, there has been a gradual decline in CAD-related death over the past 35 years. This relates to people's efforts to become healthier and advances in the treatment of CAD. Prevention and early treatment of heart disease must involve a multifaceted approach and must be ongoing throughout the lifespan. In fact, healthy lifestyle behaviors should begin in childhood. Identifying high-risk persons. Clinical signs of CAD are not apparent in the early stages of the disease. Therefore, it is critical to identify people at risk for CAD. Risk screening involves obtaining a thorough health history. Ask the patient about a family history of heart disease in parents and siblings, especially a premature history of CAD, under age 55 for male and under age 65 for female. Note the presence of any cardiovascular symptoms. Assess environmental factors such as eating habits, type of diet, and level of exercise to elicit lifestyle patterns. Include a psychosocial history to determine tobacco use, alcohol intake, recent stressful events, e.g. loss of a spouse, and psychologic state, e.g. anxiety, depression, and anger. Place and type of employment provide vital information on the kind of activity performed, exposure to pollutants or toxins, and degree of stress associated with work. Identify the patient's attitudes and beliefs about health and illness. This gives insight to how disease and lifestyle changes may affect the patient. It also can reveal misconceptions about heart disease. Knowing the patient's educational background and health literacy helps determine teaching needs. If the patient has prescribed drugs, it is important to know the names and dosages, and if the patient adheres to the drug regimen. Managing high-risk persons. Recommend preventative measures for all persons at risk for CAD. A person with non-modifiable risk factors, e.g. age, gender, ethnicity, can still reduce the risk for CAD by controlling the additive effects of modifiable risk factors. For example, a young person with a family history of heart disease can decrease the risk for CAD by maintaining an ideal body weight, getting adequate physical exercise, reducing intake of saturated fats, and avoiding tobacco and illicit drug use. Encourage people who have modifiable risk factors to make lifestyle changes to reduce their risk for CAD. You can play a key role in teaching health-promoting behaviors for highly motivated persons. Just knowing how to reduce their risk may be all the information they need to start. For people who are less motivated to take charge of their health, the idea of reducing risk factors may be so remote that they are unable to perceive a threat of CAD. Few people want to make lifestyle changes, especially in the absence of symptoms. First, help them to clarify their personal values. Then, discuss risk factors and have them identify their individual risks. This can help them set realistic goals and choose which risk factors to change first. Some people are reluctant to change until they begin to have symptoms or have an MI. Others, having had an MI, may find the idea of changing lifelong habits still unacceptable. Help them review options and respect their decisions. Physical activity. A regular physical activity program should be designed and implemented to improve physical fitness by following the FIT formula. Frequency, how often; intensity, how hard; type, isotonic; and time, how long. Everyone should aim at least 30 minutes of moderate physical activity on most days of the week. Examples of moderate physical activity include brisk walking, hiking, biking, and swimming. The AHA encourages people to increase their daily physical activity and lower the chance of developing heart disease simply by walking. Adding weight training to an exercise program 2 days a week can help treat metabolic syndrome and improve muscle strength. Regular physical activity helps with weight reduction, reduces systolic BP, can help increase HDL cholesterol. Nutritional therapy. Dietary recommendations focus on ways to lower LDL cholesterol. They emphasize a decrease in saturated fat and cholesterol and an increase in complex carbohydrates, e.g., whole grains, fruit, vegetables, and fiber. Fat intake should be about 25 to 35% of total calories, most coming from mono, unsaturated, and poly, unsaturated fats. Red meat, egg yolks, and whole milk products are major sources of saturated fat and cholesterol. They should be reduced or eliminated from diets. The high serum triglyceride level, alcohol, and simple sugars should be reduced or eliminated. Omega-3 fatty acids reduce triglyceride levels and can slow the progression of CAD. They do not affect LDL levels. The AHA recommends eating fatty fish twice a week. Examples of fatty fish include salmon, tuna, and mackerel. Other foods that contain omega-3 fatty acids include soybean oils, canola, walnuts, and flaxseed. Omega-3 fatty acids can be hard to get by diet alone. The HCP may recommend dietary supplements. Lipid-lowering drug therapy. An estimated 28.5 million American adults over age 20 have cholesterol levels of 240 milligrams per deciliter or greater. Treatment of high cholesterol focuses mostly on lowering LDL cholesterol. A complete lipid profile should be done every 5 years, beginning at age 20. Middle-aged adults should be screened every 1 to 2 years. If multiple risk factors are present, more frequent testing is recommended. Guidelines recommend the following groups of people receive statin therapy. 1. Patients with known CVD. 2. Patients with primary elevations of LDL cholesterol levels of 190 or greater, e.g., familial hypercholesterolemia. 3. Patients 40 to 75 years old with diabetes and LDL cholesterol levels between 70 and 189. And 4. Patients 40 to 75 years old with LDL cholesterol levels between 70 and 189 and a 10-year risk for CVD of at least 7.5%. Drug therapy should continue for a lifetime unless the patient becomes intolerant. In that case, the patient should switch to another drug. The patient must fully understand the rationale and goals of treatment, as well as the safety and side effects of lipid-lowering drugs. Concurrent diet change is essential to reduce the need for drug therapy. Treatment also includes weight loss, if overweight, and increased physical activity. Serum lipid levels should be reassessed after 6 weeks of therapy. If they are still high, changes in drug therapy, and more dietary options may be considered. Drugs that restrict lipoprotein production. HMG-CoA reductase inhibitors, statins. The statin drug are the most widely used lipid-lowering drugs. These drugs inhibit the synthesis of cholesterol in the liver. An unexplained result of inhibiting cholesterol synthesis is an increase in hepatic LDL receptors. This allows the liver to remove more LDL from the blood. In addition, statins cause a minor increase in HDL and lower CRP levels. Statins are not equal in reducing LDL levels. Rosuvastatin, Crestor, is the most potent statin currently available. Serious adverse effects of these drugs are rare and include liver damage and myalgia, muscle ache or weakness, without breakdown of skeletal muscle. They can progress to rhabdomyolysis, breakdown of skeletal muscles. Liver enzymes are initially monitored and rechecked with any increase in dosage. The creatinine kinase isoenzyme, CKMM, found in skeletal muscle, is assessed. Symptoms of myopathy, e.g. muscle aches and weakness, occur. Niacin. Niacin, a water-soluble B vitamin, is effective in lowering LDL and triglyceride levels by interfering with their synthesis. Niacin at high doses increases HDL levels better than many other lipid-lowering drugs. Unfortunately, side effects are common. They may include severe flushing, pruritus, GI symptoms, and orthostatic hypotension. Fibric acid derivatives. The fibric acid derivatives work by aiding the removal of VLDLs. They are very effective for lowering triglycerides and increasing HDL levels. They have no effect on LDLs. Although most patients tolerate the drugs well, GI irritability is common. These drugs should be used with caution and combined with statin medications due to increased risk for myopathy.